Good morning, dear audience. Today I'm going to present my ongoing research on the advancements in the diagnostics of skin cancer. To briefly introduce my topic, basal cell carcinoma is the most common cancer among Caucasian population, causing severe disfigurement if not diagnosed early. Current gold standard diagnostic technique, histology, is invasive. We lack a fast, non-invasive, and highly accurate diagnostic tool for the detection of BCC. Our research found that line-field optical coherence tomography and reflectance confocal microscopy showed a sensitivity, specificity, positive and negative predictive value of more than 90%. Dermatologists should consider incorporating these tools into the everyday practice to reduce unnecessary biopsies, and future research should focus on the cost-effectiveness of these tools. Policymakers should prioritize funding for these tools to make them accessible in their everyday practice. Let me introduce myself. I am Kelemen, a medical doctor and a PhD student at the Department of Dermatology. My vision is an early diagnosis and treatment of skin cancer, and my mission is to improve skin cancer detection through imaging methods. To achieve this, I have two specific goals, both focusing on skin cancer detection, the first one on basal cell carcinoma and the second one on melanoma. So let's start with the first project, which is investigating the accuracy of novel optical diagnostic imaging techniques for basal cell carcinoma. BCC is the most common cancer type among Caucasian population with a 10% incidence rate. While it is generally slow-growing and less likely to metastasize, untreated BCC can lead to severe local complications, such as disfigurement and dysfunction. Current gold standard diagnostic technique, histology, is invasive and time-consuming, while dermoscopy is non-invasive. Its accuracy depends on the examiner's expertise. This is where novel optical diagnostic techniques come in the picture, as they offer real-time and non-invasive diagnosis, and we have a wide range of tools with unclear accuracy. For example, OCT has a high penetration depth, while RCM has high resolution. So our aim is to assess the accuracy of novel optical diagnostic imaging techniques for the detection of BCC. Our clinical question is which is the most accurate diagnostic tool among these techniques, and to answer this, we built the PIRD question framework. We will compare novel optical imaging techniques to the gold standard histology among patients with suspected BCC. We hypothesize that RCM will prove to be the most accurate one, and with this, we could have a quick patient-friendly diagnosis of BCC. Here you can see the systematic search key I have used to conduct the searches in 3 databases, and we had approximately 4,000 articles. And with my lovely team, Kurush and Bashak, we arrived to 30 articles during the selection process. Let's see the results of our analysis. Here we focused on 2 main outcome parameters, sensitivity and specificity, which show us how well each tool can detect BCC when it's there and rule it out when it's not. These are the summary ROC curve, showing the overall diagnostic performance for line-field optical coherence tomography, for reflectance confocal microscopy, and for optical coherence tomography. We can see that most of the studies cluster in the top left corner, indicating a strong and consistent performance. However, we have some outliers, and the main reason for that is that we had a varying prevalence of BCC and differing populations among our studies. And for the actual numbers, we can see that RCM and LC-OCT had very high numbers, above 90%, while OCT had somewhat lower specificity and positive predictive values. Our study offered 2 key strengths. This is the first meta-analysis of several optical imaging techniques for the detection of basal cell carcinoma, and we had a relatively high patient number for all the imaging techniques. Of course, we had some limitations. For LC-OCT, we had limited studies available, and the reported prevalence, as I mentioned, was varying across the study studies which influence our comprehensiveness. In conclusion, we can say that LCOCT and RCM show the sensitivity, specificity, PPV, and NPV of more than 90%, and OCT demonstrated lower results, suggesting it is less reliable for accurate BCC detection. Our implication for clinical practice is that dermatologists should consider incorporating these tools into the everyday practice to reduce unnecessary biopsies. And for this, we would have training programs in the clinics. Our implication for research is that, of course, these tools should be researched how well they can work in real clinical life settings, and the cost effectiveness or the cost benefit of these tools comparing to histology. And also there are a lot other imaging techniques should be researched. We only had available data for 3 tools. Here you can see the progress of the first project. I'm currently finishing the manuscript, and I hope to submit the article at the end of September. Let's move on to the second project, which is investigating the diagnostic accuracy of dermoscopic scoring systems in the detection of melanoma. Melanoma represents approximately 5% of all cancer cases and has the highest mortality among skin cancers. Most widely used non-invasive diagnostic tool is dermoscopy, and as I mentioned, its accuracy depends on the examiner's expertise. And also, there are several algorithms or scoring systems that are used during using dermoscopy, and there's no consensus on the most accurate one. For example, the most well-known one is the ABCDE rule, but there's, for example, the 7 checklist method or the pattern analysis. We think that we could standardize the diagnostic process by having one highly accurate algorithm that could be used worldwide. So our aim is to assess the accuracy of these dermoscopic scoring systems or algorithms in the detection of melanoma. Our clinical question is which dermoscopic scoring system is the most accurate one? And again, we use the PIRD question framework. We will compare different dermoscopic scoring systems to the gold standard histology in suspected melanoma patients. Our hypothesis is that pattern analysis is going to be the most accurate one, and we could improve the diagnostic accuracy in detecting melanoma and by standardizing the diagnostic process. In summary, we have 2 ongoing projects. The first one I hope to finish in a month, and the second one in early 2026. I'd like to finish my presentation with a quote from William Blake, an English poet. "What is now proved was once only imagined." Thank you for your attention.
I have one question related to your first topic. So, is it easy to learn to use these devices, and does it matter how experienced is the user of the device for the result?
Thank you for your question. Yes, it has to be practiced. So, as I mentioned, to incorporate these tools into the everyday practice, there would have to be training programs for the dermatologists. So yes, it needs practice.
On your slides regarding the ROC curves, you didn't show the area under the curve values or the F1 scores. What is the reason for that? Only showed the specific sensitivity and specificity.
Sorry, what was the first part of that?
Did you calculate the area under the curve values or the F1 score regarding the ROC curves? I really missed this. Sensitivity and specificity is very important, but it would be beneficial if you can show the EUG or the F1 values.
Thank you for your question. We haven't calculated that because during our selection protocol, we noticed that none of the articles were calculating it. So to see how these tools work in the real life, we calculated positive and negative predictive values. So maybe that also helps to understand how they work in real life. But no, we haven't calculated the area under the rock curves.
Based on your results, would you recommend OCT for diagnostic in the practice?
Thank you for your question. As I mentioned, it had lower accuracy than the other two tools, but for now it's not clear how we would include these tools in the everyday practice. Of course, we don't want to exclude totally histology, so all these tools would be complementary to dermoscopy and histology. And OCT could be considered not only for the diagnostic, for the actual diagnosis, but to follow the treatment, and also to because it's very good in measuring the tumor depth. It could be used to for subtyping BCC, for example, or tumor margin assessment before or after the Mohs micrographic surgery, which is the ultimate treatment for BCC.
You mentioned that there's no standardized scoring system for dermoscopy, and are there standardized scoring systems for these other novel imaging techniques? You mentioned that the examiner has to learn the technique itself, but for the interpretation of the images, is there a standardized scoring system, or are there?
You mean for RCM, OCT, and all this? There's no protocol for that or scoring systems because they are very new and not used in the everyday protocol. There are a couple of things that you should consider when you diagnose BCC with these tools, but of course, if we would include these in the protocol, there would have to be an algorithm or a scoring system for these two.